A wide range of research that we have going on. When we talked about pharmacotherapy, people reminded us about the need for talk therapy as well. And then the talk therapy itself in many situations, and I think these were excellent examples, can often stand by themselves. What we're going to do now, because we've actually gone through our 4 lectures, is I'd like to ask the panelists to come up, Dewleen Baker, and much of the work described here came out of Dewleen's work, so fantastic material. And Joel Dimsdale, who will be chair, and I'll introduce him in a second, and Stephanie Dulawa, and David Janowsky. Just a few words about the chair, Joel Dimsdale. So I'm sure we'll change the lighting. Super, thank you. Joel is a distinguished professor at our university. He is now emeritus and a professor of research. He focuses on his career, his focus mostly on consult psychiatry. He was the editor-in-chief of a superb journal, Psychosomatic Medicine. His interests are sympathetic nervous system activities, stress, behavior therapy, but I want to mention my favorite. And my favorite is a book he just published called The Anatomy of Malice. And it's the enigma of Nazi war criminals. And it just came out in 2016. Anyway, it's extremely impressive. So we'll have a few minutes of some presentation by Joel, and then we'll turn things over to the panel. Thanks.
Thank you, Mark. You know, this is a historic day, and I am wondering if we had been in an auditorium like this 50 years ago, what we would have been hearing. What research, if any, would we be hearing, learning, sharing? And then I wondered in 2069 what our successors may be thinking about, what wrong directions we have taken, or whether we have made some good directions. First off, I wanted to introduce our discussants. David Janowsky is a professor emeritus, former chair of psychiatry at Chapel Hill, an expert in psychotherapy and pharmacology of affective disorders and alcohol. Stephanie Dulawa is an associate professor with an interest in genetics and animal models of psychopathology. And Dewleen Baker is a professor and director of research and neuroscience at the VA and studies stress, resilience, PTSD, and mild traumatic brain injury. As I listened this afternoon, I was thinking about 50 years ago and 70 years ago in psychiatry and wondering what we would have encountered. Sonia would not have been here. Sonia's topic would not have been here at all. The fact, yes, we were interested in sleep, but in a very circumscribed sort of way. The fact that we might be interested in sleep and cancer and biological rhythms, this would blow people away. And the fact that this work is flourishing now is terribly important. As Sonia alluded, the arrows go both directions. Not just that the cancer therapy is affecting sleep, but also that the sleep and chronobiology has a chance of affecting physiology and cancer progression. On the other hand, 50 years ago or 70 years ago, our predecessors would have been very familiar with all of the PTSD presentations. The graphs would look different, the statistics would look different, that the fact that we're counting on fingers and toes, number of souls we're treating and what seems to be working and not working, all of this is vastly new. But the focus on head injury and PTSD absolutely would have been spot on. Leo Eitinger in Norway followed every soul who survived the Nazi concentration camps and was interested to see who survived more or less intact. And what Leo found in this cohort was that the inmates who'd had head injury invariably had a worse prognosis. Our colleagues in the 50s and 60s were highly involved in some curious discussions about reparations. I remember going to meetings in Israel and Germany where questions of responsibility for the syndrome emerged. This question of vulnerability to PTSD is one that's been troubling to the field. And the question of blame and responsibility. Is everyone vulnerable? And if not, what's the responsibility for imposing a circumstance which results in PTSD? I think there was a little bit of, I take it back, Sonia, there was a little bit of focus on sleep and trauma 50 and 70 years ago, but the focus had to do with amytal, with barbiturates as a way of treating people's PTSD, getting people to express emotion. Whether it was an accurate recollection or not wasn't the point. That the amytal triggered recollections were helpful in resolving some of the trauma. But all of this was experiential. Maybe there was a chi-square somewhere buried in a journal, but it was spelled out, CHI square. We certainly didn't even recognize the Greek letter in our journals back then. So I'd like to thank the speakers for very stimulating discussion. I guess in 2069, if we make it to space, and if we make it to long duration space, we are going to be struggling with selecting a crew that can face constant trauma in close quarters, selecting a crew that will be able to tolerate chronobiological aberration. And we will have to come up with some electronic therapy because we will be so far away from Earth that any sort of consultation will be meaningless. We will have to have our own therapy modules. So this is for you in the year 2069. Prove me wrong. I think there's interesting challenges for the future. So for the panel.
So I think I might pick up from where you left off, and I talk about where we might go from here with. Can you hear me? Where we might go from here. Let me say first off that PTSD, I think, is one of the, have found it one of the, it's been my career, and I found it one of the, it's so fascinating because the disorder has a very strong consistency and similarity in terms of the symptomatology and the development, but each individual has a very different story. And so that I don't think that you can fully treat PTSD without engaging biologically as well as psychotherapeutically. And from my self-reflection as well as observing patients, I think the guilt. There is an injury. PTSD people may be more prone or less prone, and we're beginning to look at the genetics. Murray talked about that. But there is a major change at some point of injury, whether it be a fear-based injury, some kind of extremely aversive event that somebody observed. There's something that happens biologically that is an actual biologic injury that then progresses to full development and can take years or entire lifetime if it's and be uncured. And at that point of injury, guilt is common, and shame is common. It's part of the breach of the breach of the imaginable. That something, whether it's something fearful or something observed that's horrific or grotesque, breaches all imagination. And at that point, there's an injury that can involve shame at that happening, as well as guilt at what one thinks they might have been able to control, but couldn't at that time. And so we do, as you point out, we can see the guilt and the shame, but it's not necessarily, it's connected but to the symptoms, but the symptoms are separate and may need to be treated separately. And as you kind of showed in your talk, the PTSD symptoms came down, but they were quite high to start with. 70 is a high CAPS. 60 is still fully symptomatic for PTSD. Now, many years from now, will we understand the biology sufficiently to treat the symptoms with some kind of medication, brain stimulation, or other method? I think that we'll understand a lot 50 years from now, but I don't know if we'll understand the full core physiology or the manifestations that grow from this injury. And definitely, we are, however, beginning to see a lot of interesting information in regard to the TBI and how it can hamper sort of resolution of the symptoms. I'll stop there.
Okay, I just wanted to also briefly comment on where I think things could go in the future in the field of PTSD. And I wanted to make a comment specifically about some data that Dr. Risborough showed that I found to be extremely striking, and maybe some of you did as well, in which she showed that actually methylphenidate has a quite robust effect on reducing post-traumatic stress disorder symptoms. And I wonder if within the next decade, there shouldn't be much larger scale studies done looking at this effect. Methylphenidate is known as a very safe drug that we actually give to children and also to adults already. And other trials are already ongoing looking at new treatments for post-traumatic stress, such as L-DOPA, but they may not actually be quite as safe drugs as methylphenidate. So I hope some people in the audience might weigh in on whether they agree or not with this idea.
Okay.
Yeah.
Well, I was going to say just that I came here actually in 1973, so the department was, I don't know, very young to say the least, and then left in '86 and then came back in 2011 for 4 years down at the Gifford Clinic. So anyway, I've seen quite a few years, 46 years of this department, which has grown and been wonderful to see. It's interesting. My own focus from at least one research focus has been around the cholinergic system. And so everything I do there's a saying, if you have a hammer, everything looks like a nail. So and the other piece of it is I know almost nothing about PTSD. So I decided to apply what I know a little bit to what I heard today. The first thing I did want to comment about Dr. Norman's comments, though, about guilt and so on, two things about that. Just yesterday, I have a small private practice, and I have a patient who has very severe PTSD and very severe trauma and has been going downhill for many years, luckily not under my care. And it occurred to me that guilt is a major issue with her, and the algorithm that Dr. Norman presented, I'm going to try it because I think it might help this person to look at it from that point of view. She also, of course, has a psychologist. I'm just the psychopharmacologist, but we do talk every now and then. I was thinking about one of the issues that got brought up that's been kind of near to my heart. We get locked into studies where we do parallel studies between placebo and active drug and so on, and they go on forever, and they have tremendous amount of variation in the cases, and that's kind of how you get the FDA to approve a drug. But there are much faster and easier ways to see if something might work. For example, the initial major ketamine studies involved a crossover design where there was an A-B or BA design, and they were able, with very few patients, say 22 patients, to be able to figure out that indeed ketamine seemed helpful in depression, and we all know where that's gone into a wild rage, and even a drug company approving it, so if you work harder and pay more money, you can use the same drug you can use that's generic. Scopolamine is in the same category, except it hasn't caught on, and so the studies, the outcomes, and so on were almost the same using scopolamine as an anticholinergic agent. One of the thoughts that I've had, and that relates to the scopolamine, is that there's a tremendous number of drugs on the shelf that have psychotropic effects that have either been forgotten about because they didn't work, or maybe they were popular once and they're not anymore. I mean, I'll give you an example, which I'm not saying would be useful for anything these days, but what about reserpine? It used to cure, really help schizophrenia. What about tricyclic antidepressants? And to that end, we have Dr. Stein talking about a couple of genes that look promising, and in fact, they seem to affect spiny neurons. And so what about using GABAergic drugs on the short term, or dopaminergic, or scopolamine for that matter? One of the things about scopolamine and PTSD that I find interesting is that scopolamine blots out your memory. So what would happen if you gave scopolamine right after the explosion of your vehicle in Iraq or Afghanistan? Would it wipe out the memory or the consolidation? In fact, there's a few studies in animals, and at least one in humans of a kind of a single case, but nevertheless, scopolamine was very helpful in decreasing anxiety in a PTSD patient. The other thing, I was thinking about light and the things that Sonia had to say. And it seemed to me that light is it's obvious, and it would be interesting to do a study and see if people are fatigued if they live on the equator and have chemotherapy. But also I wondered about what would melatonin do. Has that been used for the fatigue, or lithium for that matter? The last thing I wanted to talk about was a little bit about the issue of these rhythms in the PTSD patients, the sleep rhythms. And again, cholinergic agents that actually are procholinergic, not anticholinergic, increase REM activity, REM density, REM latency is decreased, and REM intensity is increased. If that's what one's trying to do, what would happen if you gave a centrally acting low dose of cholinesterase inhibitor as a way of trying to enhance your REM activity? So those were just a couple of thoughts I had. So, okay, thank you.
Yeah, so I'm going to say just a tiny bit in response to your very long list of potential medications, which is, again, looking now versus hopefully 50 years from now. I think we understand a lot more now about the physiology of PTSD and also how some things like TBI might impact it. But the list of medicines, many of which I've actually tried in my clinical practice and seen in small studies to look like they're effective, but in larger studies not to be effective, suggests that we still know very little about the physiology, and we have a long way to go. And so hopefully in 50 years, with a lot of work, both imaging and other neuroscience work, we'll understand more and maybe have a medication that, or two, or a brain stimulation technique or two, that we can potentially combine with therapy that will be truly, very effective, and we'll be able to predict who to give it to.
And I even have a name for the drug. It'll be called Nepenthe.
We're going to be stopping in about 5 minutes, so I just want to be sure that if there's anything from the audience. These comments were wonderful. If there are any comments from the audience.
Barb?
Question about the diagnosis, the DSM-5, and the changes. It's had enormous, PTSD has always been overdiagnosed. DSM-5 came out and it opened the door to all kinds of diagnoses of PTSD. It's had a profound effect on forensics. It's had a profound effect on clinical diagnoses. I'm wondering what the effect of such a broad causation definition now is having. Both direct trauma, non-direct trauma, indirect trauma is now going to have on research and all the patients you collect that come into you with the diagnosis of PTSD.
DSM-5 strikes me as a nice menu, but isn't where I really focus in terms of making my diagnosis is the symptoms and how the person reacts when they talk about whatever the event was. And I work in the VA where normally that is, a very broad range of potential trauma events. It usually isn't the issue. I don't know, Murray or Sonia, do you want to comment on this?
There's a microphone right behind you guys.
If they don't have intrusive symptoms, and if the intrusive symptoms don't completely match the events of the whatever happened to them, I'm disinclined to diagnose them with PTSD.
Yeah, so I know in a forensic setting it's really important whether a diagnosis is made or not. Clinically, it doesn't much matter to me. So if somebody comes to me and tells me that they're having these kinds of symptoms and there are a few symptoms short of a full deck of symptoms or whatever, it really doesn't matter to me. I still, I'm going to go ahead and treat. But I understand in sort of forensic settings it's very different. But I'd argue with the point that PTSD is overdiagnosed. I think in many clinical settings we actually find it to be underdiagnosed. People are very often reluctant to talk about trauma, and clinicians still haven't gotten in the habit of asking about it, I think, as often as they do. So there probably is overdiagnosis in some settings, probably depending on where one works clinically, and underdiagnosis in others.
I think that, or we can, well, okay. I think this, and the panel and the speakers know better, but it seems to me the PTSD issue is one of stress, the old stress diathesis model. If your diathesis makes you extremely vulnerable, a minor stressor is going to cause the full array of PTS symptoms. But I'm also concerned that the current definition is too broad, especially in non-clinical contexts. The other point was on methylphenidate. I'm sure someone here knows more than I do about this, but I'd be hesitant to use what is a stimulant. I understand that if your brain's abnormal in an ADHD way, it has a paradoxical effect. But for someone with a fairly normal brain and modest diathesis, I'd be very hesitant to use methylphenidate because its symptoms and side effects mimic those of anxiety disorders. So, but I think perhaps someone else has more information about it. On the face of it, I'd be a little hesitant.
What a wonderful way to end a session, because indeed, the coffee breaks aren't for coffee. Forget about the coffee. The coffee breaks are to talk about stuff like this.